It's more than awareness, it is actually about a call to action. Namaste, ni sambula vinaka, kia ora koutou. So my name is Sandhya Bhawan.
I'm Ian Buchanan.
Kia ora, I'm Margaret Hand.
Talofa lava, my name's Dr. Neva Lawrence.
Kia ora koutou, ko Linda mai kia ora hana hau.
I'm Letitia Harding, Chief Executive of Asthma and Respiratory Foundation New Zealand.
Kia ora, ko Kevin Pewhairangi ahau.
All clinicians want their patients to reach their full health potential, but for that to happen, patients must have equitable access to the medicines that can help get them there. New Zealand's pharmaceutical funding agency Pharmac, Te Pātaka Whai Oranga, has been focused on ensuring that this is achieved, creating a document titled Achieving Medicine Access Equity in Aotearoa towards a theory of change.
Medicine access equity is about all overcoming sort of system challenges, and we have to think of ourselves as being part of the system. So all of us in primary healthcare as clinicians, we are part of the system.
As part of the system, it is crucial that clinicians look out for patients who are most vulnerable to inequitable access to medicines. Pharmac undertook research to find who these patients are.
Over 2 different time periods, Pharmac undertook research to kind of see that the medicines it has funded, whether or not it was getting to the eligible population at the right rates. And the research pieces that it's analysed, it's done comparison of the rates of access of these funded pharmaceuticals between Māori and non-Māori. And over both research time periods, the data is stark. It's actually quite sobering. It does show that Māori are continuing to get lower rates of treatment despite their higher health need. And I guess that's what really sort of made Pharmac and the leadership at Pharmac all along sort of go, well, we need to be committed to eliminating these inequities in access to medicine, because it doesn't make sense why the rates would be lower simply at the moment, that the reason seems because of ethnicity. We also know that while we've got the research really giving us a good sense of the rates of uptake between Māori and non-Māori, it is likely to be similar for our Pacific people, but also people who have a lower socioeconomic status or are living in rurality, or even coming from former refugee backgrounds. So it was really important for Pharmac to think about a strategic priority for which they wanted to be committed, and achieving medicine access equity is one of them. And they really we needed to work and inform the sector of where we stood with this. So that's really probably one of the key reasons that led to the publication itself.
To reduce inequity in medicine access, we need to look at what drives medicine equity. Pharmac did just that.
In April 2019, last year, we published a discussion piece, and it's titled Achieving Medicine Access Equity in Aotearoa Towards a Theory of Change. We published this discussion piece with the intent in mind of actually defining the problem of medicine access equity in Aotearoa. In it, we talk about the broad sort of structural inequities within which medicine access equity sits, and really identified a bit of a theory of change, or a reference framework, which talks about actually what are the drivers that we need to be working within in order to facilitate better access to medicines.
Availability, accessibility, affordability, acceptability and appropriateness are the 5 drivers of medicine access equity that can have a real impact on patient outcomes.
This particular document that we've produced, and I guess this Pharmac has pivoted its attention towards medicine access equity. It's more than awareness, it is actually about a call to action. It is about picking up the document, looking at the drivers and understanding, well, where is it that I can play a part and I play a role in this space of ensuring medicine access equity. It is about realising that while the problem in itself is really big and quite significant, that each one of us in the healthcare system can do something to make a difference, because the problem is so multifactorial and complex that if we all did our part, then I think cumulatively we will get there and achieve medicine access equity.
The first driver that can help clinicians achieve medicine access equity for their patients is the availability of medicines. Sandy Bhawan explains Pharmac's definition of medicine availability.
We looked at medicine availability, and this really is around the fact that actually if you don't have medicines available that are deemed safe by your regulatory body, then that's the first part of access. You must have medicines available that are effective, that are going to achieve the health outcomes for that individual.
Medicines must be funded and available in order for patients to have a chance of accessing them, and so it's important that clinicians be aware of all funded medicines.
That we do have very effective funded medicines available for New Zealanders in this country, and that there are some groups of our society that are unable to access this in an equitable way, and this does mean that it's taking away from their health outcomes, it's taking away from their potential to have a healthier life.
The second driver of medicine access equity that Pharmac discovered was medicine accessibility.
The second component of utilisation is actually the physical accessibility to get to a prescriber in the first place, and by this we're talking about say the location of the doctor in comparison to where you live and work. The opening hours of these services in particular includes pharmacy as well. And also with medicines, some medicines require you to complete some lab tests or have some blood tests so that we can make sure that the doses are right. So that again, I guess implies that the patient should be able to get to the lab, get their tests done on time, so that the medicines can be renewed. So that particular driver is defined as medicine accessibility.
We asked primary care clinicians what medicine accessibility looks like to them.
To me, the access to medicines also involves being able to access a source to have it prescribed for them as well. So, it's the shift worker, it's the person who's working long hours and works all during the week and long hours and not able to get and see doctors and so forth. How do they continue their care and things like that?
For Kevin Pewhairangi, a pharmacist in Gisborne, access to medicine is even more difficult on the isolated East Coast.
So Gisborne's the only place where there are pharmacies on the East Coast, and so you've got 5 or 6 towns on the way up, which can range from half an hour to 4 or 5 hours away from Gisborne, that don't have pharmacy services or a pharmacy there. So how it works for them is prescriptions are faxed down to Gisborne and they're couriered up. No advice, no education on the medications, and sometimes they don't even pick it up because they forget. So that's an equity there, just access to pharmacy.
Improving the accessibility of medicines often means reaching out to patients. Nurse practitioner Margaret Hand and nurse prescriber Linda Mahikareihana work in a nurse-led hauora centre for whangareis Te Hauā Whiowhio or Otangarei Trust.
We had a hard case time during the lockdown level 4. We are attached to the trust, so they gave us one of their workers to deliver. So we have a pharmacy that will come to the clinic, but because of COVID everything was run a bit different. So we had a worker who would go to the pharmacy under our instructions, picking up for Mr. or Mrs. delivered to their homes. He didn't give any information about medication though, he just delivered to them to make sure they still had access. We would ring them, let them know this is coming your way. If it's a new one, you get a kōrero about what it's all about. Or if it's their usual, so we just said, it's coming, so-and-so will be dropping it off into your letterbox, please be home. We found that was good access.
And we had a team that worked from home, and the team would ring all our patients and see how they were getting on, and especially those in that risk bracket, the elderly, and they were afraid to come out and they didn't want to come out, and so we try and connect with them as much as we can, and we have quite a good understanding of our population, and we did get quite a few calls for new registrations throughout the COVID-19 because there were a lot of practices that weren't taking on patients, so we ensured that we were going to go the extra mile, and we did register some of those patients as well.
Yeah.
The third driver of medicine accessibility is affordability.
Medicine affordability, so the factor of affordability, which is to do with affordability of getting to the prescriber in the first place for your initial prescriptions or ongoing prescriptions, affordability for paying the prescription co-payment at your community pharmacy, and being able to get to these appointments, which is like your transport and childcare and time off work.
The inequities that we already know are that they have a low income, around $24,000 or less. So accessing healthcare often means that you already know what the barriers are before they walk through the door.
It could be you can't afford your medicines, and that's a very real reality in Gisborne. You can't afford your medicines, you start picking which medicines you're going to take. If you're on polypharmacy, you've got a lot of medications, that's an issue. Where you should have the opportunity to have access to all your medications. That's a form of inequities.
It can be hard to figure out how to break down affordability barriers for your patients. We asked Margaret Hand and Linda Mahika-Reihana how clinicians can improve medicine affordability.
Where do you start?
Exactly. What we used to do is because we know patients couldn't afford the medications, and so a few years ago we would fill out the disability forms, we would set up the automatic payments, we would get the WINS applications set for them, we would fax it down to the Work Income New Zealand, we would go down, I was a nurse, but I was having to go down to social WINS and sit with the patients and be present when they were trying to get these forms set up, and it made a huge difference. It was a lot of work for us, just trying to sort of access care, not only for medications, because you need to go and see the GP or the MP or the designated prescriber now to get those, and in saying that of course the nurses that use standing orders, but it's a big barrier to have to jump through hoops to do that, and that's took up a lot of our time, but it was worth it. When people walk through the door and they can pay for their bill and they can pay for their medications, it has so much self-confidence and so much worth, and they're not afraid to come in.
The fourth driver of medicine access equity is acceptability.
Acceptability is about is the service that you're providing, are you able to leave the patient receiving the medicine with enough knowledge and enough empowerment about what you've prescribed, what it is for, it's suitable for them in the way that it's been prescribed or in the device that's been prescribed. You have given a lot of knowledge to the person to be empowered, and actually in the interaction with you have not judged the individual.
So, what is stopping some patients from accepting their medicines? What is stopping patients from feeling confident that their medicines are best for them?
A lot of whānau are a bit shy o whakamā, and so you just want to step in slowly, and you want to normalise things. You want to mihi atu to them, which means that you want to make them feel comfortable when you come into your clinic and in that space, and acknowledge that there's things that it's difficult to say or things that you haven't been taking, then that's okay. We've all got things that we need to do or things we haven't done, and I think a lot of patients want to tell the GP or the nurse practitioner or the designated prescriber, I've been taking that medication, I've been doing it every day, and it doesn't quite match up with the blood test results at all, so it's okay that you've missed your tablets. It's just okay to be honest and open and have a friendly conversation.
I think that's the key, it's just to let them know they're scared and I'm going to get another lecture, or they're going to give me some more tablets. It's just about having a nice, comfortable, open, honest conversation. And we find often when you do that, they're more understanding. Oh, is that what that one's for? Oh, okay. Or, so I haven't taken them for the last month, but I can start now. We find that with a lot of them.
There are many techniques clinicians can use to improve medicine acceptability. Dr. Aniva Lawrence, a GP at Te Whare Ora o Tikipunga in Whangarei, says that the way clinicians speak to patients can have a huge impact.
One of the main kaupapa of our service is to be able to empower the people that come here to take control of their own health journey, their own health and well-being, and feel empowered to do so. When we have younger junior doctors or medical students that come in into placement with us here, I often reiterate that it takes 6 years to learn a medical terms and language of how to speak, and then it takes you another 6 years to unlearn that and actually be able to communicate at the level of your own community.
There's a lot of scenarios, and I think each one and everyone's different, but I think the key thing is to say, look, it doesn't matter what you tell me, I understand, and we'll just work through it and get to where you want to be, not where I want to be as a GP or an MP, where you want to be and what your goals are.
The important message that any further questions or information, just give us a ring. We're here, just give us a ring, and we can chat to you about that. Because often they'll get home and they'll go, oh, I meant to ask, and they'll think, oh, I won't ring back because that's just going to be annoying the pharmacist. But no, that's what we're here for, and that's part of the process. And if that's going to help you to understand your medicines better, all the better, because you're having that next conversation. And the more times we have conversations with people about their medicines and their health and their general well-being, the more they become engaged.
The fifth driver of medicine access equity is appropriateness.
And the final driver in our document speaks to medicine appropriateness. This really is to do with the quality of the service that accompanies a medicine from the time it is prescribed to the time it is dispensed and to the time that it is reviewed. So it's a cyclical process, I guess.
For Ian Buchanan, treating gout is a prime example of how medicine appropriateness can be practiced.
So, as we know with gout, we often see it when people come in to buy some pain relief. They want something here now, fix it now. That's it. That's what's causing them the grief. Having that conversation, yes, we can supply something to help with that relief of the pain, but it's having that conversation to say, well, the acute flare-up is only a minor part of the condition. It's the long-term raised uric acid levels that is really of our concern, and it's talking to the patient about having ways to reduce that uric acid levels. Sometimes diet and lifestyle do play a role, but often long-term medication is really the only answer to maintain that.
There are many ways clinicians can break down barriers for their patients. As Kevin Pewhairangi explains, it can be as simple as getting a patient's name right.
Especially with Māori, it's not about going out there and learning te reo, but the most important thing would be to pronounce names correctly. I mean, give it a genuine go. There's nothing worse than watching a kuia or karawa, an elderly Māori person, have their name butchered in front of them and they don't respond. Okay, there's nothing worse than that, and that's a big issue. So that's automatically a barrier. So take the time to ask how to pronounce things, make little notes on how to pronounce the name.
For Dr. Lawrence, identifying the patients in your practice who need further care is key to improving medicine access equity.
There are lots of ways that primary care providers out there can reduce medicine inequity access, and some of these include, we know that there's already equity issues around the offering of triple therapy, which is preventative medication for those who have a high risk of cardiovascular events or who've already had a cardiovascular event, and so we know that particularly Māori receive less of that, and so being able to audit your own prescribing behaviours, being able to have resources or automated query builds within your patient management systems that can identify those who are overdue for diabetic checkups or for their regular blood tests that they're due as well too.
Chief Executive of the Asthma and Respiratory Foundation New Zealand, Letitia Harding, points to NGOs as a source of help for clinicians looking to improve medicine access equity.
Just really reach out and inquire about what NGOs are around, because the resources that NGOs such as Asthma and Respiratory Foundation New Zealand, Diabetes New Zealand, all of those big national leading NGOs have fantastic resources, and they also provide resources which are often in other languages as well. So they'll have them in Te Reo or Samoan or Mandarin. So find out what NGOs are in the country.
For Sandy Bhawan, there are two areas of medicine access equity that can easily be influenced by clinicians: the physical accessibility of services and the quality of care provided.
So I think as clinicians working in the healthcare system, we actually can influence two major areas. One is actually the physical accessibility of our services, because we control the opening times, we control the appointment times, we control how our services are organised around individuals and around populations, for example. So I think the way we provide access to the services we offer is absolutely something we all can control, but within our own particular disciplines. So how does this work for general practice teams? How does this work for nurse-led clinics? How does this work for our community pharmacy services and access to community pharmacists, for example? The other place that I think clinicians absolutely can make a difference to equity is actually around the quality of care provided. And this really speaks to that individual interaction that you're having with that patient, with their whānau, with their caregiver at the time of, again, depending on what it is that you're doing, at the time of, say, prescribing, at the time of diagnosis, or at the time of actually assessing how they're doing, or at the time of dispensing the medicine and explaining what the medicine is for, when to come back for it. These two things I think we can really embrace as clinicians and say, yeah, I can make a difference in this space, and work towards making a difference and measuring how you're doing in that space as well.
To learn more about how you can make a difference to medicine access equity, go to akohiringa.co.nz. He Akohiringa, learning always.